a practicing endocrinologist and someone who has a special interest in cardiometabolic health as a whole, we saw this sort of quote unquote class effect from SGLT2s first displayed in DAPA-HF, where it showed benefit for HFrEF in patients with and without diabetes. What does it mean to you now as an endocrinologist that this is almost all but confirmed that this is part of a class effect, that we're seeing this cardiovascular benefit from empagliflozin now?
It's great for us as prescribers and great for our patients. And what'll be interesting is when the cardiologists come on board. As you know, most cardiologists, they look at the data, they like the data, but they don't prescribe the drug. And still SGLT2s are vastly underprescribed. So I think even from when EMPA-REG showed less heart failure hospitalization, not in this population, and then it was shown in the other studies, Canvas showed that as well, then certainly Credence got the indication in the renal patient, and DAPA Declare showed it sort of as almost primary prevention, diabetes with risk factors. But there was that sub-study of Declare. If you looked at the low ejection fraction patients, they did dramatically well. That was sort of the appetizer to DAPA-HF. And now you have this. So, and then even with Vertus's lack of MACE, but benefit for heart failure, obviously this is a class effect of this class. Are they different? Do some do better than others? Well, they have different populations and stuff. The background medication makes a difference. How well treated they are. Do you have additional benefit beyond their background therapy? What'll be interesting to see in this study, because the inclusion criteria was pretty similar, the GFR went down lower. The GFR went down to 20 in Emperor heart failure and 30 in DAPA HFrEF. But what is the background meds? Like, there are a lot of beneficial background meds for heart failure. Was there the same amount of RAS blocker, or the ARNIs, where there's more Entresto in one versus the other, which makes it a more difficult bar to improve upon. Right? It's a higher bar if you have a lot of better good stuff on board for the patient to prevent heart failure, and then you prevent heart failure on top of that. So that'll be interesting. One, class effect, yes, all great for heart failure. Two, is there a difference? Can you still do better and better despite what the background therapy is? So that'll be important too.
Now let me ask you, as we learn more about the CV benefits of this class, do you think that there will come a point where it sort of becomes a decision for the cardiologist whether to describe SGLT2s in their patients that are diabetics, or is this going to remain sort of in the endocrinologist wheelhouse?
So who's treating diabetes? Primary care and endos. Endos, I think, are more aggressive with SGLT2s, but certainly there are excellent primary care docs who do the exact same thing that we do and use the same, GLP, SGLT2, and, like we do it, versus more traditional either MET-sulf or MET-DPP4 basal insulin versus SGLT2 and GLP-1. So will cardiologists do it? Well, I think heart failure has always been their domain. So will they do it and bite the bullet and say, okay, look, I'll give the primary care one shot, or I'll put it in my note, and if the patient comes back to me, I'm doing it the next time. But why wait? You could avoid that heart failure hospitalization while they're waiting. So, this class is what you're discussing with the patient in terms of if they're on hypoglycemia drugs like a sulfur insulin. I think the cardiologist will have to be comfortable with tapering that, or let the primary care doc know, I'm starting this medication for heart failure. I know they're on other diabetes drugs that can potentially cause hypoglycemia like insulin or sulf. But if they're just on metformin or GLP-1 or DPP-4, they have to know and be reassured you're not going to get hypoglycemic, so don't worry about that. And the yeast infection thing, yeah, cardiologists may have to ask patients, are you an uncircumcised man, or do you get a lot of yeast infections, or if you're a woman? And they don't usually ask that question of their heart failure patients. So, but I think, they'll come around when they see the impressive data with this as add on to the other standard of drugs that they use. it would be like saying, okay, I'm a cardiologist, I'm using a statin, but I'm not going to use Zetia, or I'm not going to use a PCSK9. That's someone else's problem because it's an injectable drug or whatever. You know, they do, if you're a lipidologist, you do lipids, and you don't have to be a cardiologist to do lipids, just like you don't have to be an endocrinologist or diabetologist to do heart failure therapy. I don't expect them to manage all the diabetes because, you know, they have enough other stuff to do, but I bet some of them do that. Either the minority do that, and certainly the minority are prescribing this class of drug for their patients. But I think they'll come around eventually. So we'll see. Depends how much hand-holding they need and reassurance that they're doing no harm.
All right, thank you for that. And now, as we move forward and we learn more about these drugs and sort of the benefits that they give, it seems a lot of people are still a little bit reluctant. It seems a lot of people still favor GLP-1s for HbA1c control and weight loss. What type of risk factors would you have to see in a patient beyond just being a diabetic for you to initiate therapy with an SGLT2, hoping to sort of see that benefit in reduced heart failure or improved renal function?
So what kind of risk? Well, first of all, they're good diabetes drugs. Remember, that's why they first came out. You know, not every diabetes drug do you not get hypoglycemia, lose weight, and lower blood pressure. So it's sort of, they call it a diabetes trifecta to do that when they first came out. And they compared very favorably with DPP-4s in terms of A1C drops. DPP-4s were the market leading branded drugs after Metsulf. But then you had Empareg, and then you had the Empareg and the other cardiovascular trials with SGLT2s. Then you had Credence, and then we'll have the DAPA-CKD, and eventually we'll have EMPA-KIDNEY. And now we have two, you know, mega heart failure trials. So I think it's enough to say, okay, I'm giving this drug early on in diabetes. Will they ever supplant metformin, which doesn't have this kind of cardiac benefit or heart failure benefit or renal benefit? I don't know. I mean, maybe because of cost, metformin will always come first. But metformin has, you know, substantial side effects. We know that metformin just had that pull with the metformin ERs, where it was very distressing for patients to call up, to get a call from their pharmacy that your drug may cause cancer. Call your primary care doc, see if they want to put you on. So, you know, I think the more of that stuff with metformin and the more cardiovascular benefits with this class, where it not only MI, stroke, and death, but heart failure and renal protection. And we've talked about this once before. If I told my chief of endocrine you had a drug that lowered A1C, lowered weight, lowered blood pressure, prevents end-stage renal disease or lowers the slope to that, treats and prevents heart failure hospitalization, and lowers MI, stroke, death, that's a pretty good drug.
Yeah.
What other drug do you have like that? So I think you're going to see a lot more use of it. It's vastly underused, even though the drug's been out several years. And cost usually isn't an obstacle with commercial insurance because these drugs have very good copay cards. So most of them with commercial insurance are free to the patient. So that's a big deal. You know, whereas it's a very generous copay card for commercial insurance, and even Medicare and the other government plans tend to cover this class of drug. May not be the one you want to use, but at least you can get an SGLT2.
And then just lastly, I know you hit it on it a little bit in your answer there, well, the latter half of your answer there. Despite some really strong data, there seems to be a bit of hesitancy still on behalf of some endocrinologists or some primary care specialists to prescribe these drugs. I've seen some figures suggest that it takes 5 years after a drug's approval for people to really start prescribing it the way they should. What do you think are some of the barriers that still exist? Because from my perspective, all the data seems really great. It seems like a no-brainer that you should be prescribing SGLT2 inhibitors to your patients. But what are the real-world barriers to the clinical application of this data and these drugs?
So still discomfort with the mechanism. Many of us grew up on sugar in the urine is bad. Now we're leveraging the kidney by blocking, you know, at the proximal tubule SGLT, where the transport system is, to leverage the kidney to urinate out sugar. So some are still uncomfortable with that mechanism. The yeast infections, what if you get burnt and you choose the wrong patients and your first 5 patients get a yeast infection? You're going to be a little slow to prescribe it on the 6th patient. You know, I personally, when I used an ACE inhibitor, early on when I used Captopril, I had a patient with angioedema. Well, imagine if I never used an ACE inhibitor after that. So, And that was 1 in 100,000. But here, yeast infections are not uncommon. And yeah, you could define, you could leverage your risk by talking to the patient. When was your last yeast infection? 20 years ago. That's different than someone, when was your last yeast infection? Oh, I have one now, and I've had 5 in the last year, and I'm on an antibiotic. That's a different kind of patient who's at risk for the yeast infection. Some are painfully fearful, who haven't prescribed the drug, of urosepsis because it's in the package insert. Well, UTIs are not uncommon. If you ignore a lower UTI and treat it as a yeast infection, you're going to get an upper UTI because diflucan doesn't work to treat a UTI. So I think if they get burnt by side effects, it takes some time to discuss this with the patient. The typical verbiage is, this drug will make you urinate out more sugar, salt, and water. It will drop your blood pressure. If your pressure's too low, you might get hypotension. You may want to cut down the thiazide diuretic that they're on. Not in a heart failure patient, they're on, loop diuretics, but you might want to back off a little bit on that loop diuretic because this has a glucoretic effect to it. And that's not going to negate the heart failure benefit effect. That it has not just a diuretic effect, there's many other benefits. The sympathetic tone goes down and other things like that. But the talking to the patient, if you give it to a man with BPH who's urinating every hour, what are you going to say? Now you can urinate every half hour. So you have to choose the right patient, give the right counseling, and have benefit with the first couple of patients you've prescribed it if you've never prescribed it before. Not that you get burnt by side effects, that the man with BPH calls you back, I'm peeing too much, or I'm thirsty all the time, or I'm passing out because their pressure was 100 to start with and you didn't cut down the thiazide, or they're on a sulfur insulin and the drug worked and they got hypoglycemic. So the counseling to a patient, that takes a couple of minutes. And, in a follow-up office visit, those couple of minutes would have been spent doing something else. So it's a decision. If you're going to start this, is not just here's your script, goodbye, see ya. The other thing is the drug works very quickly to have its benefit. The separation of the curves happen early. I think it happens within 20 or 30 days in DAPA-HF. It happened very early on. Some of my colleagues kid around and say that it happens as soon as you e-scribe the medicine, the patient has benefit. But I do think they have to put it in their mouth first, at least take it a couple of weeks. But most patients on the drug want to stay on it. And interestingly, if you had a woman with a yeast infection or a history of UTI, after it's treated, they want to go back on the drug. They know the drug caused some weight loss. The drug has these other benefits, so they want to stay on the drug. The drug might have lowered their A1C better than previous drugs. So I think the time it might take to discuss with the patient is a little more than here's your DPP-4 and move on to something else. But of course, DPP, you get what you pay for. DPP-4 is lower sugar, don't get hypoglycemia, no weight loss, no blood pressure lowering, and none of these cardiovascular benefits or renal benefits. So that's a long answer to your short question.
Sometimes a long answer is needed. It's definitely a bit of a troubling question when you see this great data and wonder why people aren't prescribing it. And just lastly, before I let you go, what exactly are you looking for when you go and watch the Emperor Reduced presentation at the end of next month in August? What are you looking for from that data as an endocrinologist?
Okay, you even know the timetable of this. It'll be right at the European meetings that will be discussed. So what am I looking for? What were the background meds that they want? How does it compare? Is it different than the background meds in DAPA-HF? Were they better managed patients? Were there more more RAS blockers, more ARNIs, more of the other standard of care cardiovascular drugs, what modernized regimen? What was different there? We know that from the DAPA presentation, I think you interviewed Silvio Inzucchi about the prevention of diabetes when that came out at ADA. I watched that, see your style, which was very good. But anyway, they may look for time to development of diabetes. How, that's different. Of course, you're going to get less diabetes. You're using a drug that makes you clear sugar in the urine. But time to development, did that go down in the average time in the placebo group? And these are in the patients who did not have diabetes. So not only prevention of diabetes, but what was the separation of those curves? How quick did that happen? So things like that, I look for that. Obviously, what was the overall heart failure hospitalization and the combined endpoint, and then how did each one individually do. So I think the background therapies would be different. The different percentages of the cardiovascular death or heart failure hospitalization, how did that go out as the primary endpoint? And then a lot of the secondary endpoints, they may have some different things. The renal benefits of the drug. Here, the GFR went down to 20. How did those patients do? How did the GFR 20 to 30 patients do? Because that wasn't studied in DAPA-HF, because I think the cutoff was 30 there. So the trials differed enough that you can get some additional data versus saying, okay, big whoop, I know this already from before, what are you teaching me new? You know, so they extended the GFR to 20. There were different background meds in the study as well. You know, maybe was there a lot of GLP use in this versus before? If it was a later study, maybe there's more GLP use in background meds. So I don't know, you know, and I'm sure there'll be some other things they point out.